Hello and welcome. My name is Temiloluwa Prioleau. I'm an assistant professor of computer science at Dartmouth College. Today, I will be presenting to you our paper, Adherence to Personal Health Devices, a case study in diabetes management. This work is being presented at PervasiveHealth 2020, and it's also a part of the Augmented Health Lab at Dartmouth College. So this work is motivated by the prevalence of personal health devices in our society today. More specifically, in this work, we focus on wearable medical devices as opposed to consumer devices. Such personal health devices enable pervasive monitoring of health and vital signs in everyday settings. However, the benefit of these devices is often directly related to the frequency of use, meaning as users use these devices, they tend to have or achieve better management. Whenever they don't use the devices or when adherence is poor, they tend to achieve not the greatest management. So adherence is critical, however, it is understudied, specifically in wearable medical devices. In this work, on the right, we show some examples of wearable medical devices. More specifically, in this work, we're going to focus on CGMs, which are continuous glucose monitors used in diabetes management. This work has two primary objectives. One is to assess factors that affect adherence or wearing behavior of personal health devices. More specifically, we focus on the diabetes context and investigate whether and to what extent achieving target glycemic goals affect wearing behavior of CGMs. So to further study this, we leverage two data sets. These are two data sets that are part of our lab, the Augmented Health Lab at Dartmouth College, collected from patients with diabetes. These two data sets include a total of 44 subjects. Data set 1 on average has 60 days of CGM data from 10 subjects, persons with diabetes, and it's shown on the top right. Meanwhile, data set 2 includes 100 to 270 days of CGM data from 34 subjects, persons with diabetes. As you can see on the right, it shows the 5 different categories, blood glucose categories, that are particularly important and relevant for assessing diabetes management. In the green is the normal blood glucose category or range, which is between 70 to 180 milligrams per deciliter. For a person with diabetes, their goal is to try to maintain their blood glucose within this normal or healthy range. However, as you can see, sometimes the blood glucose tends to go high, very high, low, or even very low. These are considered the abnormal or the unhealthy categories of blood glucose. So for someone with diabetes, your goal is to try to minimize the time spent in the not normal ranges and maximize the time spent in the normal ranges. You can also see that there are some subjects, for example, subject 4, that are considered well controlled, meaning they spend majority of the time in the normal or healthy blood glucose range. Meanwhile, for example, subject 6 would be considered poorly controlled because they have spent majority of the time in the high or very high blood glucose range. Specific to CGM, and adherence to CGM, we consider what is known as wear time, which equates to or equals the number of hours per day that a personal health device is worn. In this study, data gaps or missing data is used as a proxy for finding CGM wear time. So the figure on the bottom shows an example of 1 week of CGM data from one of the subjects in our study. As you can see, every day of the week is shown on the line graph or the time series graph by a different color. And then marked in the red are periods of missing data or what is known as data gaps. You can see that there's some periods that are longer, there's some periods that are a little shorter. There are also some periods where the blood glucose seems to be high when the data gap starts, and then the blood glucose is closer to the normal range when the data gap ends. So the last sample of blood glucose, the last blood glucose sample is used to classify or categorize the data gaps. So for example, B would be The segment annotated in B, the data gap started in a high blood glucose category. So keeping this in mind, we also evaluated the distribution of blood glucose values and existing data gaps in the 4 data sets. We observed that majority of the data was in the normal blood glucose category or the healthy blood glucose category. This equated to about 66% of the BG values that we had in our data set. However, as you can see, there are samples that are in the high and very high, and also in the very low and low categories. These are periods of hypoglycemia and hyperglycemia. So in this work, we actually focus on these periods and trying to understand data gaps that are associated with such periods. Looking into the duration of data gaps, just an observation of the data sets, we observed that the length of missing data or data gaps range from 15 minutes to 17 minutes. However, we also observed that the longest data gaps occurred in the most severe blood glucose categories. So when the users were furthest away from their target goal. So for example, as you can see in this plot here, whenever the users were in the very low blood glucose category, you tend to have, or we observed, the highest average duration of data gaps in the very low and also in the low category. Meanwhile, on this side, you also see in the high and very high categories, we tend to see the highest duration of data gaps. So this was particularly intriguing, and it led us to asking the question, are users potentially taking off their CGMs when in suboptimal blood glucose ranges or categories? To try to better study that, or better look into that question, we looked into statistical testing, and more specifically using a 2-sample t-test to further compare the average duration of data gaps in different blood glucose categories. More specifically, we used the normal category as reference. And I want to draw your attention to when we compare the duration of data gaps in very low and very high versus the normal category. As you can see, we found a significant difference between the average duration of data gaps in very low or the extreme blood glucose categories compared to the normal blood glucose categories. This observation leads to or informs that the duration of non-adherence is significantly associated with the severity of suboptimal management. So in more severe or extreme blood glucose categories, we tend to see longer durations of data gaps. Meanwhile, in normal categories, we tend to see shorter durations of data gaps. However, looking at this at a subject level, that was a general observation. At a subject level, you notice and we observed that this phenomenon is not particularly generalizable across all subjects. For example, as you can see on the right, some subjects like subject 3 and 5, this observation seemed to hold true, meaning they had longer durations of data gaps in the abnormal blood glucose categories, significantly longer than they did in the normal category, and same for subject 5. Meanwhile, for example, for some subjects like subject 1, there was no significant difference between the durations of data gaps when they were in the normal blood glucose category versus when they were in the abnormal. So of course, this leads to the finding, but also emphasizes the idea that this finding is personalized. It doesn't apply to all subjects, but it was present and observed in some particular subjects, and it was statistically significant. Moving on to group level analysis, we also evaluated or separated the subjects into subgroups. One subgroup was well-controlled versus poorly controlled, and this is based on, or this categorization was based on the average blood glucose, which the threshold used for this is hemoglobin A1C, which is a clinical biomarker for diabetes, where a hemoglobin A1C of 7 is considered the threshold between well-controlled versus poorly controlled diabetes. So this hemoglobin A1C of 7 equates to an average blood glucose of 157 milligrams per deciliter. Similarly, we separated subjects into older versus younger, just using the median age, and then also considered just the differences between each of these subgroups. I want to draw your attention to the glycemic target using the hemoglobin A1C of 7%, and we see that there was a statistically significant difference between subjects. More specifically, subjects with poorly controlled diabetes had significantly worse adherence to their CGMs than subjects with well-controlled diabetes. So these are some observational findings that we found in this study, or we identified in this study. So just to reiterate some of the key findings, we observed that suboptimal blood glucose values is one factor, certainly not the main factor, but one factor that is significantly associated with wearing behavior. We also observed that longer data gap durations or periods of missing data is significantly associated with extreme blood glucose categories. I want to note that this is an association and not a causal relationship, as was found in the study. However, this introduces a critical dilemma because personal health devices are designed and intended for monitoring health status to inform treatment. However, if users are not wearing these devices when achieving suboptimal health outcomes, that defeats the purpose, and it actually also biases the data that is present in such devices. So with that, looking forward to some recommendations from this study. The recommendation is that particular attention should be paid to adherence to personal health devices, especially prescription personal health devices. In addition, data-driven analysis can provide insights surrounding patterns of non-adherence and support targeted interventions that improve health outcomes. As wearable personal health devices become a reality in other domains outside of diabetes, data-driven adherence analysis should be included in embedded algorithms. So with that, I say thank you for listening. And for more details on this paper, please feel free to reference the full paper, which is cited here. And also, you can contact me directly. My name is Temiloluwa Prioleau. My email address is stated here, and also my personal website. You're also welcome to look into the Augmented Health Lab at Dartmouth College. Thank you so much for listening, and thank you for your time.